So good afternoon. I'm Giuseppe Barbesino, one of the endocrinologists here at Mass General. I work in the thyroid unit, and I see mostly patients with thyroid disease. And today we're going to go over, the way I see thyroid ultrasound. There are many different ways to do this. We'll go through some basic principles to see how they apply to thyroid. And then in the last section, and maybe the largest section, what I'm hoping to do is to present you with images, involve you into reading them, telling me your opinion on what these nodules look like. So let me see if I can advance these slides. Okay, basically, sonography principles indicate that the sound moves through matter with compressions and decompressions. These decompressions transfer energy from molecule to molecule, and they generate a sine wave you're familiar with. And there are two important measures of the sine wave. The amplitude is the loudness. In a way, we don't hear it ultrasounds, but there is an amount of energy that depends on the amplitude. But for us, what is most important is the frequency. So how close every single wave is to each other. A difference from many radiology devices, in sonography, the signal that is emitted by the same machine that also reads the signal, and that is the transducer. The transducer is able to transform electrical energy into ultrasounds, and this is done through the vibration of crystals in the probe. Excuse me. These crystals generate the wave, and then when the wave is reflected back onto them, those crystals will vibrate again and generate electric energy that then is transformed by software into a map of images. So the same thing, when you do X-rays, you have a gamma ray emitter and a film on the back. Here, the film is the same thing as the emitter, and the probe is really the most important part of your machine. We talked about the importance of the frequency. Here I show the different effect of frequency on the different ultrasounds. So for example, if you have a 7.5 megahertz probe, the distance between the waves will be larger. And that results in a lower resolution. You can see how something that is in between two waves is not going to be spotted because the waves are separated. And so the resolution of a 7.5 megahertz probe will be smaller than a 12 megahertz probe. However, the penetration, which will be much larger with a lower frequency probe, because much less energy is dissipated through its passage through the tissue. So the bargain here is that if you want higher resolution, you're going to have to accept lower penetration in the tissue. And we'll see how in the thyroid this is particularly important, because the thyroid is a superficial organ, so we can afford high resolution ultrasounds without too much loss of signal. And so here's the typical probes that we use: a 12 megahertz linear high definition, and you can see it has a lower depth, but enough to reach the thyroid. And then a 7.5 megahertz curvilinear probe, typically, which has a lower definition but better depth. And most of the times we use a 12 megahertz in the thyroid, but there are times in which we will need to use a lower definition to reach and particular anatomic structures. And sometimes it's just the conformation of the neck. As you know, unfortunately, there are thicker and thinner necks, and sometimes a curvilinear probe is necessary. And again, if there is anything that is unclear, please stop me or send a message in the chat. We will be able to address questions this time. So here, this diagram shows to you on the top how the probe generates an ultrasound. And the way the ultrasound works is that an ultrasound is reflected back to the probe each time it hits an interface. An interface is a change in phase in the matter that the ultrasound is crossing. So for example, here we have solid tissue, nothing gets reflected because it's homogeneous. Then it hits fluid, and all of a sudden the phase is changing, ultrasounds are being sent back, the crystals are excited, and they will generate electrical signals, and you'll get the picture design. So some ultrasounds will go anyways through the interface and reach the second interface at the end of the fluid-containing structure, and then again, new signal is going to be sent back to the probe, and the probe will understand that this left a little sooner than this one, and so we'll have a map of the distance between the two signals, and that's how the bidimensional image that you see on the screen is generated. There are some things that are important to know. The most important is that air does not transmit ultrasounds. So everything that enters air, every ultrasound will get dissipated without being able to generate an image. And that's why we cannot see anything behind the trachea in the neck, because the trachea contains air and the trachea cannot generate ultrasound. So nothing that is behind the trachea can be imaged by ultrasound. Things that are solid, for example, metal, will reflect ultrasounds completely. You see, for example, here's a solid obstacle to the diffusion on ultrasounds in tissue, and you can see that all of the ultrasounds are reflected back. The machine will read this as an extreme intensity of signal, and this in the map of colors that you can see in the grayscale will be very bright white. Everything that receives a lot of ultrasounds is white on the machine, on the images that are generated. So you'll see a very bright signal. Because nothing goes through, no ultrasound are reflected behind this mass, and as a consequence, everything will be dark behind the obstacle, and that's what we call a shadow. That's what we typically see, for example, with kidney stone in renal ultrasound. There is a little bit of scatter around the obstacle. Some signal may actually come back from behind the obstacle, and that's important because the shadow may be smaller than the obstacle. And this is important because when we have small reflecting solid materials, the shadowing may be enough to cover completely, the scatter may be enough to cover completely the shadow, and so you may not see shadowing. And we'll see how this is particularly important in the thyroid because we see little objects like small calcifications that can generate a very bright signal and at the same time do not produce a shadow. The density of the crystals is important in determining what is the shadow, and because of that, the non-shadowing or shadowing property of obstacles is relative to the equipment that we use, meaning a single object like this may generate a shadow in one ultrasound machine of some brand and may not in another brand. So unfortunately, there is a little bit of dishomogeneity on how machines generate images. And that also applies to the software that interprets the signal received from the probe. So there is a very large variety of images that you can obtain in the same structure from different machines, something very important to remember. So this is kind of the simple man on how we see ultrasound. If there is any question on this, I'm sure if you talk to a physicist, it'd be much more complicated, but this is a way to remind myself on how interpret ultrasound signals. Any questions about this? Good. So we can move forward now on how we see normal thyroid on ultrasound. As I mentioned to you, the most important thing is that the thyroid is very superficial, so it is accessible to this nice 12 megahertz probe. Sometimes it will be extended to 14 megahertz or even 18 megahertz. There are some software implementation that at least in theory increase the frequency of the probe. The other thing that is important to know about the thyroid, that the thyroid is made of follicles, these large follicles. And large follicles are really an alternation of solid tissue with fluid. So what are these if not a large number of interfaces? And I did tell you that ultrasounds are reflected each time an ultrasound hits an interface. And that is why the thyroid is so amenable to sonographic imaging, because it has a structure, a tissue structure that is going to generate a lot of ultrasounds as the probe signal processes them. And I told you that every time there is an interface, a white signal is reflected back to the probe. And so you can see the thyroid, a difference with many other structures, it has this nice gray texture. This is a normal thyroid. Look, you can see it in the longitudinal view. and it has this nice gray texture. It is in the middle on the gray scale that is reported here, and it is exactly what the ultrasound does. It is because each one of these gray dots is a small interface, a normal large follicle hit by the ultrasound generated by the probe. For contrast, look at this. This is a strap muscle, very homogeneous. It doesn't have follicles. So the ultrasounds will cross them very completely. And so you will not have a lot of interfaces. All you see, it's dark. And that's because no many ultrasounds are reflected back. So here we have a composite image of the two lobes of the thyroid on a transverse image. So I want to start here and ask people, again, that nice gray zone, etc. I want to start people to identify the other structures that you can see. For example, what is this? Anybody want volunteer, break the ice? Anyone in the chat?
Is it connective tissue?
Well, what exactly connective tissue sits in the neck lateral to the thyroid?
The sternocleidomastoid muscle?
Exactly. So this is the sternocleidomastoid muscle. And as I mentioned to you, it is characterized as a very dark texture with some septations, right? The muscles have septae. And so those are interfaces, generate sounds, but the muscle is crossed very promptly by ultrasound. This is the strap muscle in front of the thyroid. And this is the skin with the different layers that do reflect echoes. How about this? What is this?
Right carotid.
This is the right carotid artery, and you can see the round. And again, it contains fluid, so it does not reflect any echoes. What about this?
Esophagus.
I'm sorry?
Esophagus.
Exactly, that's esophagus, and you can distinguish it by this triple layer, typical structure, very clear. Never mistake this for a nodule. It is the esophagus. If you are in doubt, ask the person to swallow, and you'll see bubbles of air in the saliva that appear as they cross the esophagus. Here is the trachea. There is a lot of reflection from the cartilage. The cartilage doesn't let any ultrasound go through, but the air dissipates promptly. And you see the shadowing because the air, the trachea is round, but nothing gets generated from behind the trachea because the ultrasound that entered the air will dissipate rapidly and will not be able to reach the area behind the trachea. Any questions about that? All right, let's move on to alterations in thyroid tissue. Autoimmune thyroid disease, Graves' Hashimoto's, and subacute thyroiditis. I grouped them together. We do ultrasound mostly for thyroid nodules, but it is very helpful in autoimmune thyroid disease, and it's important to be familiar with this. The hallmark of autoimmune thyroid disease is a hypoechoic pattern. And the reason for that is that the follicles are, to a great or small extent, replaced by an inflammatory infiltrate. An inflammatory infiltrate is made of cells that are packed together quite tightly. And because of that, they don't generate a lot of echoes. So a lot of echoes go through. The machine reads that as a dark pattern, which we call hypoechoic. It can be diffuse in severe form or scattered when the inflammation is focal, patchy throughout the gland. There is fibrosis that can be seen with septations, and often there is increased vascularity. So here is a comparison of a normal thyroid here, and you see again the very nice gray texture, which is in the middle of the level here, and you see the distinction with the strap muscle in front. And here you see a thyroid that is enlarged. You see that kind of curvilinear profile. It gives you the idea of being globoid. But the most important thing is that it is much darker than this. It is as dark as the muscles. This indicates that the normal follicular structures have been replaced by something else. In this particular case, it is lymphocytes. Now, can we say whether this is Hashimoto's thyroiditis or Graves' disease? Who wants to answer?
You can't tell. You can just tell that there's an autoimmune process, right?
Right.
Or
You cannot tell whether this is Graves' disease or Hashimoto's. They can look the same. So when the radiologists say, well, there is a pattern consistent with thyroiditis, they can't say that. And we wrote a paper to explain that to them. They haven't read it because they continue to say it's consistent with thyroiditis. But the critical thing is having this hypoechoic pattern in any inflammatory condition that involves the thyroid gland. And as I mentioned to you, it can be patchy. For example, here you see most of the thyroid still has the granular typical normal, but you can see the several areas of hypoechoic tissue, and this is very typical of either Graves' disease or Hashimoto's thyroiditis. And if you look at this in the microscope, you basically see a lymphocytic structure here and follicular structure in this area. And if you think about your pathology, you remember that Hashimoto's thyroiditis is distinguished in focal or diffuse. Sometimes you can see that the pattern is kind of a more continuous than here, but also you can see that the thyroid have started to shrink. And that's the end stage of Hashimoto's thyroiditis, in which the thyroid sometimes can become atrophic and sometimes completely disappear. Now, we said that we can distinguish, but it is very important to understand that what is the meaning of the flow in color flow Doppler in autoimmune thyroid disease. If you see very pronounced color flow Doppler in a person who's hyperthyroid, they have Graves' disease. If they're hyperthyroid and they don't have any color flow Doppler, they have some forms of thyroiditis. So that's how you can distinguish thyroiditis from Graves' disease. But if they are hyperthyroid, if someone has Hashimoto and they're either euthyroid or hypothyroid, they also can have abundant thyroid flow. So you can distinguish hyperthyroid Graves' disease from euthyroid or hypothyroid thyroiditis, but you can distinguish Graves' disease from hyperthyroid thyroiditis, and that is because you don't see any flow in thyroiditis and you see it in Graves' disease. I think at this point, I want you to be very clear on this, and I want to stop for a second to see whether there are questions on this. Excellent. Sounds like it's clear. Okay, I think we can now move to the nodules, to what are the features that we look at. And I broke them down in several features that are important in determining the likelihood of malignant in nodules, because that's all we want from an ultrasound. We want to be able to measure the nodules, which is very easy, very reproducible. And then we want to have an assessment of what is the likelihood of that nodule being malignant. So we'll start with the texture, and we distinguish an anechoic versus hypoechoic versus isoechoic texture. So this is a nodule that is darker than the surrounding normal thyroid tissue. So that's what we call hypoechoic, okay? Is it anechoic? No, it's not anechoic, because you can see some echoes are being generated inside the nodule. So this could be a very compact tissue that doesn't reflect any echo or very few echoes, or it could also be dense fluid with some debris inside that generates some echoes. So we can't tell whether this nodule is solid or not solid, because it's hypoechoic enough to be compatible with the dense fluid, but it's also compatible with very packed homogeneous tissue that doesn't reflect any echoes because it doesn't have any interfaces. This, in contrast, is a nodule that has the same structure as the same texture as the surrounding thyroid. So much so that it's even hard to distinguish the nodule. It's a little easier here. There is a little halo around it, but you can see that this is what we call a isoechoic nodule. It's solid. Certainly, it's not fluid filled, and you can already start thinking, why do they have this echo structure? Well, you can think that there are many interfaces inside, and so you can start thinking, well, this is the same follicular structure as the thyroid. So it's a nodule that has not lost the follicular structure of the thyroid, but it could have follicles that are very small. And so this is compatible with a structure that is benign very often, for example, in an adenoma that has follicles, or it could be consistent with a follicular neoplasm, a malignant follicular neoplasm, not very likely, but possible, because those follicular neoplasm do have microfollicles, and they do tend to generate echoes to a variable extent. So that's important of recognizing the structure of an isoechoic nodule. Anybody wants to say what this nodule is like?
Cyst.
Well, but we wanted to know the term, how do you describe this?
Anechoic cyst with acoustic enhancement.
This is an anechoic nodule because it doesn't generate any echoes, and only fluid can do that. And so you can tell that this is an anechoic nodule, and as it was mentioned, is a thyroid cyst. Another feature I want you to bring your attention to is the posterior enhancement. You can see these dense, bright echoes behind the nodule, and we'll talk about them in the next few slides. It's important. These are, because so many echoes are going through this nodule, then many are reflected when they hit an interface. And because of that, the machine gets discombobulated a little, and it's confused, and they say, well, I don't know where they are, these echoes, but I have to make it all white. And so this is what posterior enhancement is. And it's seen behind a cystic structure, but not only. You can see posterior enhancement behind solid structures that are compact enough to have a lot of through transmission, a lot of echoes going through them. So posterior enhancement is not proof of a cystic nature, but it's important to recognize it for other reasons. We also try to define, and you'll see that in some scales, how we want to distinguish very or mildly hypoechoic nodules, because the risk of malignancy is higher in very hypoechoic nodules. And here, the benchmark is the muscles. We compare the echogenicity of the nodule to muscles. So this nodule, it's a little brighter than the muscles, right? So we call, but it is darker than the thyroid. So we call this nodule mildly hypoechoic. And that's a lower risk of malignancy than this one, that it is very hypoechoic. It is as dark or maybe darker than the muscles. And so because it is difficult to quantify echogenicity in a reproducible way, in a numerical way, I find that this way of comparing it to muscles that serve as an internal control for the setting of the machine, for the neck of the patient, etc., is the most adequate to grade the echogenicity in a way that is necessary for some of the grading systems. Now, this is several studies. They're now a little old, but they all show that hypoechoic nodules have a very good specificity for malignancy, but a relatively low sensitivity. What it means that most thyroid cancers are going to be hypoechoic, but there are many benign nodules that are hypoechoic. And the reason is thyroid cancer, the most common thyroid cancer is papillary thyroid cancer. Papillary thyroid cancer loses the follicular structure. The cells are very densely packed, and therefore they're very likely to be hypoechoic. But there are many nodules that are hypoechoic without being malignant. Second feature is calcifications. We distinguish microcalcifications that are typically described as bright spots that are non-shadowing. Macrocalcifications are calcifications that are generating a shadow, and they can be discontinuous or continuous. And then you have ring calcifications or eggshell calcifications that surround the nodule as an eggshell. And these are pretty easy to distinguish. Microcalcification is very complex, and the point that modern classifications don't refer to microcalcifications anymore, but tend to refer to reflectors, because sometimes it's unclear whether you can call a reflector a calcification. Let's start from the easy one. This is a typical eggshell calcification. The whole nodule is surrounded by calcium. Now, you can see the calcium very well in the part of the nodule that is perpendicular to the direction of the beam, because that reflects a lot of echoes. As it becomes less perpendicular, you can imagine that some of the echoes are going to be scattered sideways. And so that's why the machine says less echoes back, and therefore this looks like it's not as thick and less bright. But it's not that this is, the calcification is thinner. It's just an artifact of the way these echoes are being generated. So much so that when the echoes become parallel to the capsule that is calcified, it doesn't generate any echoes anymore. But you can be sure that it's calcium here and it is calcium here. That's just the way this is look. And if you are not convinced, you can we put the probe lateral to the neck, and you'll see that now this part will be bright and this part will be dark. Important to recognize. You cannot see anything behind the nodule, and that's because we have a shadow. Okay, this is the typical shadowing that I was referring to. And this is a longitudinal view, and this is transverse view of the same node. Sometimes you have calcifications that are not continuous. We call them fractures. And they're considered to be a little more dangerous. And you can see here that there is some shadowing here. You can see that some through ultrasound image is being generated. There are some calcifications here, but it's not continuous. It's not like an action. You can see that this is what we call fractures calcification. Again, fairly easy to identify, mostly because you'll find some shadowing almost always in these calcifications that are large enough not allow for any scattering from the probe to be reflected back and mask the shadow. There are sometimes linear calcifications that are not associated with a nodule. And those are, again, very typical, a linear calcification. And then you can see the shadow behind. I don't know what these mean, but they're not, if they're not associated with a nodule, you don't have to worry about that. And sometimes they look like this. Because calcifications can occur after hemorrhages, I think this may be related to neck trauma somehow, but it's my theory, and don't quote me on that. But they don't necessarily represent a concern for malignancy if they're isolated. And then you have bright reflectors that could be classified as microcalcification, and this is the most important part to be able to recognize. This is a large nodule. This is a trachea. The image is not perfect, it's an old image, but it's a large mass, and you can see these scattered and irregular bright reflectors that do not generate a shadow, and they're not associated with cysts. And so these are what we call microcalcifications. In the right context, this is a young girl with a very firm, palpable nodule that turned out to be a papillary arterial cancer with multiple psammoma bodies. That's what bona fide calcifications are. They're psammoma bodies. And you can see that this is a very, once you see a few of these, you'll never forget them. The problem is that there are many images that are in between. And there are also artifacts that mimic microcalcification. Here's an example of some bright reflectors. But there is a difference here from what I showed you before. These don't generate any image behind. These images here, they generate a sort of a white smudge behind the reflector. And what these smudges are actually what I showed you before. It's posterior enhancement, meaning there's something here that reflects so many echoes that the machine gets discombobulated and doesn't understand at what distance behind the generator of echoes is. And these are what we call comet tail artifacts, and they're generated by microcystic changes within the nodule. If you bear with me, you can see that each one of these has a little darker area in front of it. And those are microcysts within a colloid nodule that generate these reflectors. And when you see these artifacts, this is a benign nodule. It's a colloid nodule. It is very important to distinguish them from microcalcification because these are actually a marker of benignity. And again, there's many radiologists who don't understand this well. And to a certain extent, I can understand them. They just, they don't want to miss anything. They will call anything a bright reflector. But if you're careful enough, you are able to distinguish a large majority of these. And there is going to be images that leave you in doubt, but this is something that you want to be very clear on. When you recognize microcalcification well, the specificity is very high, meaning very few benign nodules have real microcalcification. The sensitivity is low because a lot of malignant nodules will be just hypoechoic and will not have microcalcification. And the meta studies have shown this. Margins, we distinguish regular versus irregular versus ill-defined margin, and I want you to pay attention to distinguish the distinctions between irregular and ill-defined, because there is a distinction. Some people are tend to mix them together, but they don't have the same meaning. And then the margins are all important because we also tend to consider the relationship of the thyroid margins to the thyroid edges, because they could indicate extratherodal extension of a potential malignancy. Any questions so far? I asked that to take a break. I see that there are comments in the chat. Is there anything in the chat that, because I can't see the chat, unfortunately. No? Okay. So this, for example, is a nodule that is hypoechoic, as I described to you, very hypoechoic, very similar to the muscle. And you can see that it does have regular margins. You can see very well that the nodule is oval or circular. And so you can imagine that this is a growth that is homogeneous. It's growing into the thyroid on a sort of a radial distribution. And so this is a nodule with a regular margin. I put this nodule here because also you can see that the nodule abuts the thyroid capsule, right? So it's a nodule that, if malignant, would have the potential of extending extratherodally, and also the posterior margin is in contact with the trachea, right? So those are things that you can observe. It doesn't mean that the nodule is malignant. I want to be clear. Any benign nodule can protrude from the capsule, but it tells you that if the nodule is malignant, it has a greater potential for harm because it doesn't have a long growth to make before it can invade extratherodal tissues. And so because of that, sometimes we use a lower size threshold to biopsy nodules that are in this position. Now, what is this image like? You can see a hypoechoic area within the thyroid, and these are very ill-defined margins, okay? You can never tell where the nodule starts, where it ends. The margins are very confusing. This is what we call ill-defined margins. They're not defined. This is actually not a nodule. This is a subacute thyroiditis, often read as very suspicious from radiologists, but this is actually non-suspicious. This is a frequent pattern seen in focal inflammatory diseases, most often with painful subacute thyroiditis, in which the margins are ill-defined because the inflammation is kind of more intense in an area and is trying to invade the rest of the thyroid, but has not really encompassed the whole thyroid yet. If you put the finger here, it will hurt terribly. If you put the finger here, it will hurt less. So this is subacute thyroiditis with ill-defined margins, not a marker of risk, as opposed to a nodule with irregular margins. That doesn't mean you can see the margin everywhere here, but you can see that doesn't have that nice round or oval shape that you've seen in the first nodule that I showed you. And this is what we call irregular margins that have a increased risk for malignancy. And actually you can see this nodule also abutting the capsule, also touching the trachea. So it's a nodule that if malignant has potential for harm, and the irregular margins make it more likely to be malignant. And again, it is a hypoechoic nodule. Flow pattern. I don't put any images for flow pattern because the flow pattern of nodules has been now discarded as a potential malignancy factor. It's too irreproducible, it's too difficult to gauge, and we don't use the flow to grade the risk of malignancy in thyroid nodules, but it does have a use. When there is a nodule, when you are in doubt whether the nodule is solid or not, you can turn the flow on. And if there's flow in the nodule contains vascularization, which makes it non-cystic. Any nodule that has no flow is more likely to be cystic, even if the content is dense, is hypoechoic, but not anechoic. And so that's the only use I make of flow pattern. I'll skip it for now. Shape is very easy because it's measurable. The shape indicates when in a transverse image, a nodule is taller than wide. very easy to measure. If it's taller than white, the risk of malignancy is high. This is a nodule that is also hypoechoic. It may have calcifications inside, but the taller than white makes it a nodule that is suspicious for malignancy. As opposed to a nodule, your standard, again, isoechoic nodule that is wider than tall, okay? And this is a nodule that is much lower. Very reproducible, easy to obtain. There's no subjectivity, you measure it. But you have to remember to measure it in the transverse images, not on a longitudinal image, okay? That doesn't count here. It cannot be taller than long. It has to be taller than wide. Very specific. When you find that, it's very specific for malignancy in many studies. It is not very sensitive because most nodules that are malignant are not taller than wide. You don't see that feature often. And so unfortunately, it's not very sensitive. And then there are nodule features that are associated with benignity that you can distinguish immediately just after you make your eye. It's very easy to, without going through all these features, you just see a nodule and you recognize that they're benign. And the most important one is the pattern, a spongiform nodule, which is a pattern of intermixed solid and cystic features in which the cystic lesion do comprehend at least 50% of the nodule. And that's kind of factitious. To be honest, I have a lower threshold for calling a nodule spongiform. I don't require 50% occupation by cystic, but this is a typical nodule. It is a colloid nodule. Once you learn them, it's very easy. You don't need to bother doing anything else. You see this nodule, you decide whether to do a biopsy or not, depending on the size. Some people will still do a biopsy in some of these where they're very large, but most often these nodules are benign. Then you have a cyst with a colloid clot inside. That's also very unlikely to be malignant, although this has been revised by later studies. They're looking at the different shape of the clot. Sometimes this is debris that is not tissue, and the way to figure that out is to turn the flow on. If there is flow, it's live tissue. So sometimes it could be a thyroid cancer, but if you see no flow, that's clot, and you're not going to need to biopsy those. This is called the giraffe hide. It's a nodule that you see very often in Hashimoto's thyroiditis. I like to call these Hashimoto's pseudonodules, and they are uniformly benign. They're just isoechoic nodules within a hypoechoic gland of Hashimoto's. You see, similarly, this is the white knight, also a brighter nodule within a dark Hashimoto's gland that's also benign. Other patterns of benignities, again, this is another spongiform nodule. This is really not nodules, it's thyroiditis. I showed you one similar case with focal infiltrates. And these are colloid cysts. They do generate often a single central, and this is again a comet tail artifact. You saw it before. It's a little smudge behind this. I think these can be crystals that vibrate as the ultrasound hit them. And so vibrating, they generate echoes at different depths. But this is very typical benign pattern. And again, another mostly cystic nodule with very little tissue. These are all benign patterns. So with that, we go briefly through the different systems that we have. There's several, but I go through the ones that are mostly used in the United States. The American Thyroid Association came out in 2016 with their guidelines. They have a bunch of patterns. You are required to recognize the pattern. You don't have to identify every single feature. You just go through the patterns. And there are very high suspicion features like a very hypoechoic nodule with calcifications, a hypoechoic nodule alone with irregular margins, a hypoechoic nodule with lymphadenopathy, and then the intermediate suspicions, which is mostly solid nodules that are just mildly hypoechoic, but with regular margins. And then low suspicions, but not zero suspicion, are the solid isoechoic nodules with the regular margins. And some of the partially cystic sometimes can be malignant, but they're with eccentric solid area. And then you have these very low suspicion, the spongiform that I showed you. And then you have partially cystic with these kind of spongiform regions, and this mostly cystic without this eccentric solid area, most of the solid tissue is in the center. So those are very low suspicion, and then benign. It's an entirely cystic nodule. And so the ultrasound, these features help deciding when doing a biopsy. These guidelines are going to be revised this year. So unfortunately, this is going to be old soon, but they haven't come up yet. So they're still standing. Any nodule that is smaller than 1 centimeter is not biopsy, no matter what it looks like. It's very suspicious with biopsy above 1 centimeter. If they're solid isochoic or mixed solid and cystic, FNA recommended if they're greater than 1.5 centimeters. If they're spongiform, they don't recommend an FNA until it reaches 2 centimeters. And then when it's over 2 centimeters, they kind of makes and they say maybe you can consider it no strong recommendation. If they're cystic, never do an FNA. And those are the American Thyroid Association recommendation in a nutshell. But then the American College of Cardiology came down with a different method, which is basically looking at different features and assigning a score to each one of them, a weighted score, somewhat weighted. It's not very well weighted because it's more, it's not really well graded, but it does assign a score to each one of these features. You can see that solid has 2 points, mixed cystic and solid only 1 point. If it's hypoechoic, 2 points. If it's isoechoic, 1 point. It's very hypoechoic, meaning darker than the muscles, is 3 points. And then taller than white, 3 points, because that's very specific and very solid. And then lobulated or irregular margin, ill-defined margin, which is what I showed you before with the thyroiditis, has 0 points, as I explained to you. While lobulated or irregular margin, as I showed you before, it does mean a risk of malignancy. And then if there is extrathyroidal extension, they look at where the nodule is pushing towards. And then the most important thing is the echogenic foci. Microcalcification, rim calcification, and microcalcifications are important in understanding the nodule. So there's something wrong here because I had the calcifications here and somehow I must have skipped some of these things. No, I showed you the microcalcification. I'm sorry, I put it back. I apologize. And so it's important to distinguish the calcification in microcalcification, rim calcifications, and microcalcification, which are the ones I showed you before. And then you take each one of these and you put them into a score. You give them a score, and then depending on the score, the ACR, American College of Radiology guidelines, will give you a instruction on how to distinguish or how to behave nodules. If above a certain size, only if mildly suspicious. The smaller, the higher the suspicion, the smaller the size required for proceeding with a biopsy. And so these patterns have been validated. This is the American Thyroid Association pattern. They show you that as you proceed through the patterns, you have an increased risk for malignancy. And similar, the American College of Radiology pattern also, as the score increases, you have an increased risk for malignancy. And so I think I'm going to stop here with the introductory part. And now we're going to go to cases. And I would like you to sort of help me in diagnosing some of these. Okay? So let's look at this. I'm sorry, there's something wrong with my slides, unfortunately. There were other things that I wanted to discuss with you. Yeah, I think I skipped something. I apologize. I'm going to go back and look at I don't know how, but somehow my slides went forward. So let's go back to the calcification and let's go back to look at them. I apologize. I don't know what happened. The slides went back. Did you see the slides going forward?
Yeah, we saw them.
Okay, so the microcalcifications are very important in terms of sensitivity and specificity when they're well identified. And this is a number of studies that look at sensitivity and specificity of microcalcification. And as you can see, they're very specific and not very sensitive because many nodules don't have microcalcification. Another pattern that is important to recognize is margins of the nodules. And we do look at regular versus irregulars versus ill-defined. And we need to distinguish the relationship of the nodule with the thyroid edge. So here, for example, we have a nodule that has regular margins, as opposed to a nodule with irregular margins, and a nodule with regular margins. And well, I think I skipped a part, but we can move on to the cases, which I want to be the most interactive part for you. Okay, so there are some cases here, and I would like you to interact with me and tell me the patterns. Anyone, don't be shy. And just after what I explained to you, tell me what you think of these nodules. Anyone is willing to describe this nodule here? Anybody wants to break the ice?
It's isoechoic partially cystic.
Isoechoic partially cystic, perfect. And why do we call it isoechoic?
The density appears similar to the surrounding tissue.
Right, so what this tells you is that it's similar to the surrounding tissue. And most likely, this is because it has the follicular structure preserved. So there are follicles that generate a lot of echoes. And so you can say that this nodule is unlikely to be malignant, but it could be a follicular adenoma. But unfortunately, some follicular carcinomas also are going to be benign, are going to be isoechoic because they have a follicular structure that is preserved. Anybody wants to describe this? What do you think? How would you describe the thyroid here? Anyone? So this is a thyroid with no nodules. It's a very hypoechoic thyroid. You can see that it's almost as hypoechoic as the muscles, and it is highly vascular. So this is autoimmune thyroid disease. Can anyone tell me whether this is Graves' disease or Hashimoto's?
Graves.
Why do you say that?
Flow.
Increased blood flow.
Yeah, so if the person is hyperthyroid, this is definitely Graves' disease. Because if this were to be hyperthyroidism from subacute thyroiditis, for example, then it would be without any flow. However, someone has with euthyroid Hashimoto's, it would look the same. So without knowing the TSH level, you cannot really tell whether this is Graves' disease or euthyroid Hashimoto's thyroiditis. And that's the point I wanted to make with the slides, the slide here. How about this? Any taker? How do you describe the thyroid on a longitudinal view?
There's no distinct borders.
Well, so what is this? So this is the thyroid capsule in a longitudinal view, which is thickened, and the parenchyma, the thyroid, is dark as the muscle. So this is a hypoechoic pattern, and so this is autoimmune thyroid disease. Whether it's Graves or Hashimoto's, you can't tell because you cannot see the flow, but it's compatible with autoimmune disease. Anybody wants to describe this appearance? We've seen that picture.
Thyroiditis?
Say that again, please.
Subacute thyroiditis.
Excellent. And why do you say that?
Ill-defined.
Borders.
Exactly.
Margins.
So what's the texture? Let's be systematic. What's the texture like? Compare it with the muscle.
Hypoechoic.
Hypoechoic.
It is hypoechoic. It has very irregular margins. Okay. And it is kind of semi-diffuse pattern. So that's very typical of subacute thyroiditis. You can imagine if you put the finger here, the person is going to jump. Anybody wants to describe this nodule?
It's a hyperechoic nodule.
Okay.
It looks like white knight.
Excellent. That's exactly why I put it here. And why do you say that?
It doesn't look like a typical nodule. I mean, like it's part of the autoimmune thyroid disease.
Right. And you say that because the rest of the thyroid is hypoechoic. It's, again, as hypoechoic as the muscle. And the nodule is solid. In theory, it would be isoechoic in a normal thyroid, but it is relatively hyperechoic to the rest of the thyroid. And this is a pattern that we see in Hashimoto's thyroiditis. And those nodules are always benign. They're always benign, so much so that it's one of those benign patterns that I've described to you before. Any taker for this one?
That's a interrupted calcification nodule. It doesn't look like an egg-shaped calcification because there's an interruption in there.
Right.
Left
So
upper
this,
corner.
yes. So these are discontinuous calcifications, almost continuous, but discontinuous to a certain extent. There is shadowing here. And sometimes there you can think that there might be some extra, some extension outside the calcification. These are, when they're discontinuous, they have a relatively high risk of malignancy as opposed to when they're continuous, which is a lower risk for malignancy. Any taker for this one? So here's the nodule. You see my arrow, right? On the screen, do you see it? You see the pointer? You see the pointer?
Yes.
Any taker from this? So this is a nodule. Remember what we said about the nodule that are always benign? These are spongiform nodules, okay? This nodule here is a spongiform nodule. It's mostly cystic, greater than 50% cystic, and it has these multiple little cysts throughout. You can argue that maybe there is a nodule here, and without the live images, it's very hard to figure it out. But this nodule here could be a solid nodule if it were separated from this. But this, I put this up because a typical spongiform nodule, a nodule that typically does not strictly require biopsy. Any taker on this one?
It's a solid nodule with, looks like a well-defined borders in there.
Okay. So a well-defined nodule, solid. And how about the texture? What do you say about the texture of this nodule? What does it look like?
It seems to be isoechoic.
Isoechoic. And why do you call it isoechoic?
it's the same ecotexture in the beside it, like the upper portion of it.
So if I describe this nodule, I call it a solid isoechoic nodule with regular margins. I don't know the blood flow. I haven't seen it here, but it doesn't really matter a lot. And I don't see calcifications, and it is homogeneous. So these are nodules that, for the most part, are benign, but they have the potential for being follicular adenomas or follicular carcinomas, or so-called follicular variants of papillary thyroid cancer. And you can imagine in your imagination that if you look at the histological structure of these are nodules in which the follicular structure of the thyroid is preserved, and therefore it generates enough echoes to make it isoechoic to the surrounding thyroid tissue. And so that's why we could call it follicular variant of papillary thyroid cancer, which are not papillary thyroid cancer anyways, but follicular thyroid cancers or follicular adenomas. How about this one? Anybody wants to describe this one? Any takers? Don't be shy. So let's do systematically. One person tells me, what are the margins of this nodule like?
Regular.
Regular, perfect. Second is, do we see calcifications in this nodule?
No.
Excellent.
And mildly hypoechoic.
Exactly. This is a mildly hypoechoic nodule. And the reason I'm saying that is that I don't have normal tissue here. Maybe here you can see it. But I have the muscle here, and it's almost as dark as the muscle. And remember, I told you the threshold for very hypoechoic versus mildly hypoechoic is really the muscle. So something that is brighter than the muscle, but darker than the normal thyroid is mildly hypoechoic. And something that is darker than both is very hypoechoic. And that has the different score in the system that we have.
I have a question. As far as the margin on that, neighboring the trachea, would you consider that to be ill-defined, or you kind of, see the rest of it, like the other 3/4, how it's round, and you would just say regular?
So I think the margin is regular. You have to remember that the trachea generates a little shadow because of its structure. So behind the trachea, you don't really see well, and that's where it becomes a little fuzzy. But I would say this is a nodule with regular margins, with the exception of that. Now, if you suspect that there might be invasion of the trachea, you can never tell, because you can't see through the trachea with the ultrasound. It is bordering with the trachea for sure, but whether it's invading it or not, you can never tell on an ultrasound, unfortunately.
Gotcha.
How about this one? Any takers? You're reading your ultrasound or you're doing the report. How you describe this?
Regular margins and isoechoic.
Yes, maybe a little hypoechoic, minimally hypoechoic if you compare, for example, with this part here. But yes, I would agree that it's a solid nodule, a regular margin. And you can also see with your microscope that this is made by many, many follicles, because each one is generating an echo. And if you stick a needle in there, you probably will have a mixture of fluid droplets and solid tissue. Anybody wants to comment on this nodule? Describe it. You're the sonographers. Anyone? Any takers?
It's an isoechoic complex nodule.
Well, so it's an almost entirely solid nodule. Usually, so unfortunately, the terminology is somewhat unclear. So what do we mean by complex nodule? Usually, we indicate a complex nodule, a nodule that has significant solid and cystic components. And you can argue that these areas here that are dark are certainly filled with fluid, made it complex, but the major component of this nodule is solid. So this is a nodule that is isoechoic and large. And so this is a nodule that has the potential for being an adenoma, but also a follicular carcinoma. So I would consider a biopsy of this nodule.
So what would you consider it as pure solid? Because there's some cystic component in there.
It is mostly solid. I do agree with you that there's cystic components, but it is mostly solid. It's probably greater than 85% solid.
So you read that as a solid?
Yes, I would describe it as a mostly solid nodule. I wouldn't go as far as call it a spongiform. Remember, the spongiform definition requires that at least 50% needs to be microcysts or moderate-sized cysts. So that I wouldn't call a spongiform nodule. So it is mostly solid. Unfortunately, it's important to realize that even in nodules that are solid, there might be cystic components that are not actually cysts. They might be necrosis or big blood vessels. So you have to be careful when you consider these spaces as necessarily cystic by the pathology. And so I really do consider nodules like this equivalent to a fully solid nodule.
Are there macrocalcifications in center of that nodule?
I don't see any microcalcification here.
I said like macro, like large, like the wider.
So what is the hallmark of a macrocalcification that we saw before? What do you need?
A shadow.
A shadow.
Yeah.
So I don't see
comet tail.
Yeah, so I don't see any shadow.
Mm-hmm.
Okay, any taker on this one? Let's be systematic and describe this nodule. And there's one thing I have to say, that when you show images like this, you lose a lot. The ultrasound is really a live test that is based on a pattern that is generated in your brain by a large number of frames. And when you take one still image about that tremendous amount of information that you receive when you're looking at the ultrasound screen, constantly generating images, you lose a lot. And that's something you want to keep on your mind all the time. We as endocrinologists, I don't know if you're endocrinologists, all of you, but we do like to do live ultrasound as opposed to the radiologists that get images taken by technicians. And that is because you lose at least 30% of information by looking at still images. Unfortunately, in this particular setting of the lecture, we can only look at still images. But, and so there is a limitation here. But, and so some of the interpretations may be made difficult by the fact that we're looking at two single frames that don't give the whole story. But anyone taken here and willing to describe this nodule?
Hypoechoic with microcalcifications and irregular margins.
Excellent. So I was hinting at the fact that the still images give away, don't give everything away. I will tell you that this nodule, in fact, has regular margins. But in a still image, sometimes it's difficult to see that. But if you were to look at several sequences, you would see that there are regular margins here. The nodule is hypoechoic. And the question whether these are really microcalcifications or not is an important question. And I will argue that I would define these as being bright reflectors, but not necessarily microcalcification. You can see two features here that make it suspicious that these are actually microcystic changes within the nodule. One, these white smudges are all linear. They're all parallel to the direction of the probes, which make me think that this may be posterior enhancement. Then I don't know how well this shows on your screen as well, but you can see that each one of this has a little darker region in front of it. You can see this. So this could be simply posterior enhancement in front of microcysts. I remember when I described you the posterior enhancement, then through fluid, the ultrasound machine gets a little discombobulated and generates a lot of bright reflectors. So I do think that these are actually microcysts with some posterior enhancement. As I said, there is a continuum between real artifacts and what we call microcalcifications or bright reflectors. So I will give you the benefit of doubt, but I don't think that these are microcysts with posterior enhancement. And I want to stop here to see whether there are questions about this, because this is a very sticky point. And one of the reasons why, when you look at studies, the microcalcifications are great specificity and sensitivity, great specificity. And then when you do it in practice, everything gets called microcalcification and gets very diluted. Any taker on this one? Here's the nodule.
It's a solid nodule with
go ahead.
Seems to be like, I don't know, there's a defined border, but it cuts off on the right upper corner there.
Right.
Yeah, so it looks like it's a background of thyroiditis, you know, so it might be part of the autoimmune process, like a white kind of nodule.
Right, and so in that setting, this is a nodule that is called a white knight nodule, and it's a nodule that is benign. It can be ill-defined, but it's a pattern that we recognize as a benign pattern. And so I want to put this image here because there are patterns that the ATA, the American Thyroid Association, uses, and then there are the American College of Radiologists patterns. You know, and so if you go by the American College of Radiology, will say, well, this is a solid isoechoic nodule. It'll give you a risk factor, and you're done. But if you go by the American Thyroid Association, you say, well, this is a nodule that is within a thyroid that has thyroid autoimmune disease. It is relatively hyperechoic. This is one of those nodules that we see in thyroiditis that are benign, and you don't go for a biopsy. And I want to contrast these two different ways to look at the nodules that are somewhat discrepant at times in the reading. I have to tell you that the American Thyroid Association pattern recognition is probably not going to survive because most of the ultrasound are read by radiologists. They read radiology papers and radiology manuals, and the ACR is taking over almost everywhere. But for someone who does a lot of ultrasounds and has that kind of intuition, using the American Thyroid Association system is still quite viable on my mind, and it is very much quicker than the American College of Radiology. Any takers on this one? Well, this is very hard. This is someone with thyroid autoimmune disease. They have a hypoechoic pattern, but within it, there is a lot of bright reflectors, And these could be calcifications. And what kind of thyroid cancer do you see in the context of Hashimoto's thyroiditis in a young person with a lot of calcifications or samoma bodies?
ETC?
I don't go well with abbreviations.
Oh, papillary.
Papillary thyroid cancer. Yes, but what variant of papillary thyroid cancer do you see? In a young person with Hashimoto's thyroiditis.
Like sclerosing kind of papillary thyroid?
Yes, and it's called diffuse sclerosing variant because it does migrate through the thyroid in cord-like structures. So it doesn't often generate a real nodule, but you can see a lot of samoma bodies. And those are really the bona fide calcifications. And although here is really hard to make up your mind, you don't see a nodule and you see a lot of bright reflectors. So you have to be very, very concerned about this and the potential for being a malignant nodule.
So do they present as like a palpable hard nodule?
Yes, there is. Well, it may feel like a nodule, but usually the whole lobe is enlarged, but very hard.
Thank you.
Any takers on this one? This is an old image done with an ultrasound that is not very good, but here it does give a message.
It's a hypoechoic nodule. It looks like there's an extrathyroidal extension because it goes into the capsule there.
Well, so that's a good point. So first of all, it's a nodule that is taller than wide, right? You see how it's taller than wide?
Yes.
So I explained to you that when the diameter of the taller than wide, it's a marker for malignancy. I don't know whether it's extrathyroidal, but it is certainly on the capsule, on the thyroid capsule. And so this is a nodule that you have to be worried about, even though this is small. And so I brought this up only because of it's taller than wide. Any takers on this one? Anyone? So this is a nodule that is a solid nodule. Okay. It does have some cystic changes inside. So I'm not able to call it a spongiform nodule. But it does have some bright reflectors here. So the question, are these calcifications? Any takers, are these calcifications or are they not calcifications?
No, because there's no shadowing effect.
Well, we said that the microcalcifications may not have shadowing.
They're all linear, so probably not microcalcification.
Exactly. So these are posterior enhancement behind some little cystic changes. The nodule remains mostly solid. It's not a nodule that we can call spongiform. It doesn't have that 50% cystic changes that is required for a spongiform nodule, but it certainly is not a nodule with calcifications that I can see. Any questions on that? And what I'm trying to show here, that sometimes things cannot be very, very efficiently categorized. And sometimes we have to have some marginal doubts on the images that we see. The nodules don't always read the books, and also the equipment that we use is sometimes different. And so they generate artifacts that may be different. Any taker on this one?
Isoechoic, well-defined nodule.
Say that again, please. I cannot hear you.
Isoechoic and well-defined margins.
Exactly. Do you see calcifications?
No.
Exactly. So this is a typical isoechoic nodule. With it is also in the context of a thyroid autoimmune disease here. I think the thyroid is hypoechoic, so it could be one of those nodules that we see in that context. But this is very well circumscribed, very solid. This is a solid nodule that is isoechoic. Let's move through some of these. Any takers on this one? These are small nodules. I put them here only as an example.
Are those cystic nodules with some internal necrosis? Or
well, we don't know whether it's necrosis. Probably not necrosis. But
yeah,
but those are those nodules that I showed in advance that are typically colloid nodules, colloid cysts, with some echogenic material in the middle, which I think are crystals that vibrate and generate those images on the ultrasound. But I cannot be sure. But I think they're crystals, and they generate. And this is a uniform marker of benignity. These nodules don't need any investigation, even when they're large. Any takers on this one?
cyst with a colloid clot?
Well, so I don't know if a colloid clot, but certainly there is some tissue here. So first of all, it's a cyst. This is completely anechoic. And there is some tissue here that could be denser fluid, or it could be solid tissue. What do we do to find out?
Vascular flow?
Yeah, we turn the Doppler on. If there is no Doppler flow, this is not tissue. So this is a cyst with inhomogeneous content, or if there is flow here, then we have to worry about some hypoechoic material that is vascular, therefore is live tissue within the nodule. Unlikely. Most likely this is a cystic nodule with different density of the material inside the cyst. A quick taker on this one.
The cystic, anechoic, regular margins, no echogenic foci.
Right. And what's this?
Posterior
Like a
shadow.
Well, it's not a shadow because a shadow is dark. We call it posterior enhancement, which is the opposite of the shadow. How about this one? Any taker?
Is that a spongiform nodule?
Yeah, so excellent. That's what I call a spongiform nodule, even though if you were to do a calculation, you would see that the definition of spongiform nodule requires that greater than 50% is cystic spaces within the nodule. And this is probably not greater than 50%. So, but I kind of allow for that. And I do think that this is a spongiform nodule, therefore a colloid nodule that is most likely benign. And I put it here exactly to make the point that the definition of a spongiform nodule is really a nodule that has greater than 50% cystic spaces within it. But nodules don't always read the book, and therefore they don't have necessarily 50%. But I do think that this is a low suspicion nodule.
Sorry, a question about the spongiform nodules. So how do you recommend follow-up of these nodules? Of course, you said in the initial slides, more than 2 centimeters, consider NFNA. But if there's no change, like, do you monitor these yearly like the other nodules, or less frequently because of the most likely benign nature?
Well, so there are two guidelines. The ATA suggests biopsy possibly if it's greater than 2 centimeters. But the American College of Radiology, a true bona fide spongiform nodule does not require biopsy at all. So it's a difficult question. Unfortunately, sometimes you can be fooled, and I do biopsy them if they're larger than 3 centimeters or so, and therefore I monitor them. But there are different guidelines and different recommendations based on which set of guidelines to look for. Now, you have to recognize the American Thyroid Association guidelines. They're older, and that's why there is a new edition coming out than the ACR guidelines. And but also it is clear that the ACR guidelines will miss some thyroid cancers. And the American Thyroid Association will miss less thyroid cancer to the expenses of more thyroid biopsies, which will lead to more surgeries for inconclusive FNA. So you have to decide where you put your fear. Are you more afraid of missing a thyroid nodule that is a small malignancy, or you're more afraid of causing a surgical complication to remove a nodule that is suspicious and then turns out to be benign? So that's kind of where the balance is. And this has been tested, it's been compared, and it's clear that the ATA is a little more conservative than the ACR guidelines. Takers on this? Well,
It is.
Yeah, go ahead.
Sorry, it is solid with taller than wide and calcifications. I think it's mostly isoechoic.
Well, so it is almost as dark as the muscle.
Oh.
So it is hypoechoic. You can see that these are linear spaces that they have, I don't know how well it projects on your screens, frankly. I hope you can see it well, but you can see that there is dark material in front of each one of these. So these are probably microcystic changes. Just to tell that sometimes there are odd appearances of nodules, and you kind of have to accept that and describe the nodules without judgment. And so you can see here, this is to me, it's a hypoechoic nodule that may be solid, but maybe there are microcystic components here, and I don't see calcification, but it's very sizable. So this is a nodule that, because it's a little unclear, I would consider certainly doing a biopsy. And you know, these nodules, I put them here, and I don't know, I don't remember the biopsy result of these nodules. I put them here just because that's to simulate what happens in the office. You don't know what they are. And so, but I'm sort of judgment-free putting these nodules here so that you can see them and decide what to do about them.
So, sorry, it's a previous slide. How can you tell the difference between the nodule and nodular lymphoma?
So lymphoma is very difficult. First of all, lymphoma almost always occurs in the setting of Hashimoto's thyroiditis. The lymphomas that I've seen, which is not many, they have had a hypoechoic, very homogeneous pattern with lymphadenopathy. Occasionally, I've seen isoechoic nodules that turned out to be lymphomas. But there isn't a specific ultrasound pattern that'll make you suspicious of a lymphoma necessarily. I do not see cystic spaces, though, in lymphoma, and these are microcystic spaces, so I don't think this is likely to be a lymphoma. It's usually very homogeneous, no matter what the texture ends up being. Any takers on this one? So let's start from the texture. What does the texture look like to you? Is it isoechoic, hyperechoic, hypoechoic?
It's hypoechoic.
Excellent. How about the margins? Are they
irregular margins?
Irregular margins. Are there calcifications?
No.
You may be right, but it is hard to tell. Sometimes it is hard to tell. Are these microcalcifications? Maybe, even though these don't look like. So sometimes you have to be humble and think about maybe there are calcifications, maybe not. It's not always obvious. And I put these nodules here just to tell you that sometimes it's simply difficult. And so when I read an ultrasound like this, I would say there are potential bright reflectors, unclear whether they're bona fide microcalcification or not. There are irregular margins, and the nodule is hypoechoic. Any takers on this one? This is a longitudinal view of the entire thyroid lobe.
Hypoechoic and with the irregular margin.
Where do you see the nodule? This is an entire thyroid lobe.
So there's no thyroid nodule in here. This is like classic for like autoimmune thyroid disease. It looks very like, nasty looking, but it's part of the autoimmune process.
Well, it could be that there is Hashimoto's thyroiditis, but there are multiple calcifications throughout this gland. It's impossible to see these bright reflectors in bona fide Hashimoto's or Graves' disease only. And the fact that these are actually calcification is given away by the fact that when they are very dense, they actually produce a shadow. And that's a telltale that there are calcifications. Only calcium can generate shadows in the thyroid gland, only calcium. And so these are calcification. You see this shadowing here? This is, again, a diffuse sclerosing variant of thyroid cancer arising in a Hashimoto's thyroiditis with multiple calcification throughout the gland. And so that's a pattern that you don't see very often, but it's important to be able to recognize it because it's very, it's a disease that needs to be recognized. Let's move through this one. Any takers on this one? Well, again, this is a bad picture. It's an old picture, but one make it the case here that there are bright reflectors. They reflect echoes, but also they cause a shadow. You can see shadow. These are dense calcifications. When you see a shadow, no matter what they look like, it is calcification because only calcification produces shadows in the thyroid gland. And so this is a nodule that has margins that you cannot really see, but it does have calcium content, and the calcium is irregular. It's not a nodule with regular calcifications. So this is a nodule that has to be regarded with suspicion. Any descriptor? We're about to finish, but I'm willing to stay a little longer if you want to. Any descriptor for this? This is an easy one. Don't be shy.
Spongiform?
You can call it spongiform, although the definition of spongiform is you have multiple small cysts throughout. You can also call this a complex nodule. So a complex nodule is a nodule with mostly cystic, but also solid tissue that it's kind of eccentric and going towards the center of the nodule. These are nodules that are benign. In the ATA, they are described as a low risk, less than 3% risk of malignancy. And in the in the ACR, they would be also not submitted to biopsy. Any takers on this one?
It's an isoechoic nodule, iso to hypoechoic with interrupted calcification.
Well, so with nodules that are peripheral calcification, it's very hard to call them isoechoic because the shadowing generated by the calcification obscures the content of the nodule. So you can't tell what the content is, okay? So this could be solid isoechoic, it could be cystic, we just don't know. It is true that it looks fractured, but for the most part, it's actually continuous. Remember, as I explained to you, that as the calcification becomes parallel to the ultrasound beams, the calcification disappears because it doesn't reflect echoes back into the machine. It bounces them laterally, maybe, or it doesn't bounce them at all. And so this is a nodule for which, well, you can argue here there's a little bit of discontinuity, but I would call it a rim calcified nodule that has a low but not zero risk for malignancy. When they're fractures, they're more broken. You can see the fractures and the different thickness of different parts of the calcification. All right, any takers on this one? This one should be easy by now.
Hypoechoic with irregular margin might be microcalcification.
So why do you call these microcalcifications?
Are those comet tails?
Exactly. This is a nodule, there is a small nodule. I agree with the irregular margins, but in the context of comet tails, which are generated by colloid, this becomes a benign appearing nodule. And that's I put this nodule here because I want you to distinguish calcifications for comet tail. It is not always easy. And I showed you examples when it's not clear. But these are clear-cut comet tail artifacts. They're not calcifications, and they are findings that suggest the benignity of this nodule. And I do not recommend a biopsy in a nodule like this. Maybe this is the last one. We can describe this. Someone should be able to describe this. Any takers?
It's hypoechoic, but it looks like it has microcalcifications, but with a regular margin.
Right. So I put this example to show you how sometimes it's not obvious. It does have irregular margins a little. It is bordering with the trachea and with the capsule of the gland. That doesn't mean that it's invading that. It's just that it is a cancer. It may be able to invade them. It does have some bright reflectors that could be calcifications, and it is hypoechoic. So this is a nodule that, depending on the size, you may want to biopsy. Some people will say, well, if you're not sure that is intrathyroidal, you'll biopsy these even if they're very small. The unfortunate thing is that in the isthmus, like this nodule is, they're always going to be like that, just because the isthmus is thin. So any nodule will almost immediately reach the trachea and the capsule, the anterior capsule. So many nodules will look like this without necessarily being cancerous. Any takers on this nodule?
Very hypoechoic and regular margins.
Yes. Is this a solid nodule or a cyst?
Solid.
I'm sorry?
Solid.
Most likely solid, but you can't really tell. It could be a cyst with thick fluid inside. And the way to tell would be to turn the Doppler on and to see whether there is flow or not. And here you go. You were right. It's a solid nodule. But I put this here just because I want to make the case that the only use of the flow is to look at whether there is actual circulation within the nodule that rules out a cystic nature of the nodule, as opposed to a real cystic nodule like this one. We've seen that before, but now I'm adding the flow, and you can see that it is no flow in the real cystic nodule. And I put this just to make that point in what is the use of flow in the evaluation of thyroid nodules. All right, I could go out for hours, but time is running short. So I want to stop here and see whether there are any questions or comments. If not, I'll let you go for dinner or breakfast or whatever you're doing in your part of the world right now. And I thank you for your attention.
Thank you.
Thank you.
Thank you.